Welcome to The Deep Dive, the show dedicated to extracting the most vital, truly mind-expanding insights from complex topics, just for you.
Great to be here.
Today, we're plunging into a battle that's been waged for millennia, mostly unseen, within our very own cells, the fight against viruses. We're talking about antiviral chemotherapy, excluding antiretroviral drugs, and our mission is to give you an elite-level understanding of the kind of knowledge that, professional experts possess.
Yeah, covering how these drugs work, the formidable challenges they face, and, frankly, their revolutionary impact on human health.
Exactly. It's a critical field, and I guess it really stems from understanding what viruses truly are.
Right. Obligate intracellular parasites. That's the key term. They're unique. They can't reproduce on their own, can't make energy, can't even build proteins.
They absolutely have to invade a host cell.
They have to. They hijack its machinery, essentially force it to replicate new viral particles.
Yeah.
And this whole process, entry, replication, spread, it can cause significant damage.
To our cells, tissues, even whole organs, which makes the need for countermeasures for these antiviral drugs just so vital.
Absolutely vital. That vulnerability in their life cycle is what we target.
So that's the core challenge. We've sifted through, extensive, often highly technical source material to distill the most critical knowledge. We want to cut through the jargon so you can truly master this information like the elite professionals in this field.
It's going to be a fascinating journey, I think. We'll go through complex mechanisms, specific drug families.
And we promise to make it accessible and hopefully engaging. Lots of those aha moments that connect the dots.
Indeed. We'll start by truly understanding the viral enemy and the core principles of antiviral action. That term obligate intracellular parasites, it's not just academic jargon. It is the guiding principle behind all virology.
Their absolute dependency on a host cell. It's their weakness, but also their strength in a way.
Exactly. And this basic knowledge, how viruses infect and replicate, it's the bedrock for everything else.
Literally all medical studies in this field. Viral pathogenesis.
How they cause disease, yeah. Vaccine development, antiviral drug design, even using viruses therapeutically sometimes.
Right, like in gene therapy or fighting cancer, knowing their inner workings is definitely step one.
It really underscores that the fight against viruses is, it's dynamic. It's an evolving chess match. And having a broad, deep knowledge of their biology is absolutely essential for being prepared for the next epidemic or pandemic.
We've certainly seen how quickly a new virus can disrupt everything. Our response capability really hinges on this scientific insight.
Totally.
So how do we fight back? Let's get into the antiviral drug mechanisms, attacking the viral life cycle strategically.
Okay, so the most common strategy, kind of the foundation, is inhibiting viral DNA or RNA replication.
Stopping them from copying their genetic material.
Right, if they can't copy, they can't make more of themselves, stops the spread.
But that's not the only target, is it?
Oh, far from it. And this is where it gets really interesting. Antivirals are incredibly specialized. They can disrupt many different crucial points in the viral life cycle. Some drugs block the virus from even entering the host cell, like a bouncer, basically.
Yeah, keep them out.
Others interfere with viral RNA transcription, how the virus translates its genetic instructions.
Or they might prevent the cutting up the cleavage of viral proteins by a protease enzyme.
Exactly. That's essential for assembling new virus particles properly.
Some even stop the virus from uncoding after it gets inside.
Yeah, stops the genetic material getting out of its protective shell. And others prevent the new viruses from releasing from the cell, traps them inside.
So this huge diversity of targets means antivirals are rarely like a one-size-fits-all kind of thing?
Almost never. Each drug is usually highly specialized, designed for a very specific step in a particular virus's life cycle.
Which is good for fewer side effects maybe, but means you need a whole arsenal of different drugs.
Precisely. A broad arsenal for different threats.
Now let's talk about something critical. The difference between what the drugs do and what our immune system does. And latency.
Yes, this is a vital distinction. Antiviral drugs, powerful as they are, they mainly inhibit viral replication. They don't usually eliminate the virus from the cell itself.
They put it to sleep, but don't kick it out.
Kind of. For true viral clearance, getting rid of it completely, the host cell's immune responses are paramount. The drugs basically buy time. They reduce the viral load, giving your immune system a much better chance to mount an effective response and clear the infection.
And then there's latency. Those sneaky viruses like herpesviruses that hide out.
Right, they can lie dormant in your cells for years, decades even. Antivirals typically don't eradicate these latent infections. They only inhibit replication when the virus reactivates. when it wakes up and starts copying itself again.
Which is why you get recurrent cold sores or shingles. The virus just reactivates.
Exactly. Which leads us straight into another major challenge: viral resistance.
The constant foe.
Viruses are masters of adaptation. The main way they resist drugs is through mutations in their proteins, tiny genetic changes.
And that alters the drug's target, right? So the drug doesn't work anymore.
Bingo. And the rates aren't uniform. Resistance isn't uncommon, and it's particularly frequent for RNA viruses, like influenza or hep C.
Why is that?
Their copying enzymes, the RNA polymerases, are just sloppier. They make more mistakes, more mutations, compared to DNA viruses.
So they evolve faster, basically. It gives them an edge in developing resistance.
It does. And this difference explains a clinical pattern. Drug-resistant DNA viruses, like some herpes viruses, are often a bigger issue in immunocompromised patients.
Their immune system is weaker, gives resistant strains more room to grow.
Whereas drug-resistant RNA viruses, they can pop up even in healthy people.
Yeah.
Just because of that higher mutation rate. Resistance is just more likely to happen.
It's really a dynamic battle inside the patient then, a mix of resistant and sensitive viruses.
Yeah, a constantly shifting mixture. You put drug pressure on, the sensitive ones get suppressed.
And the resistant ones get a chance to take over.
That's the problem, which is why the strategic solution is often combination therapy.
Using more than one antiviral at the same time.
Right. Combine drugs with different targets, or, crucially, different resistance patterns. Makes it much harder for the virus to resist everything at once.
Improves the odds of keeping the virus suppressed long-term.
Significantly.
So how do we track this fight? Assessing efficacy, figuring out administration.
Well, antiviral testing comes in when patients aren't responding or their response fades. For some viruses, we sequence specific viral genes, looking for those resistance mutations.
But for others?
It's more laborious. You actually have to grow the virus in the lab with different drug concentrations to see if it's still susceptible. It's time-consuming.
And monitoring the response. It used to just be clinical, right? How's the patient doing?
Traditionally, yes. But quantitative PCR has been a game changer. We can directly measure the viral load in the blood for viruses like CMV, hepatitis B, hepatitis C.
Gives a much clearer picture of how well the drug is actually working.
A much more precise objective measure. Then, administration routes systemic therapy, like pills or IVs, circulating through the body.
Usually more effective.
Generally, yes, compared to topical therapy like creams. But the trade-off is systemic therapy is more often linked to side effects.
So it's always a balancing act. Effectiveness versus side effects.
Always.
Okay, let's unpack this even more. Let's dive into specific antivirals, starting with segment 2, herpes viruses. Huge family, common stuff like cold sores, shingles, but also more severe diseases.
Right. And we have to start with a real pioneer family, the acyclovir family. Acyclovir itself, valacyclovir, fanciclovir, penciclovir.
Acyclovir's mechanism is pretty neat, isn't it? The whole prodrug thing.
It's elegant, yeah. It's inactive until it gets inside the body, and specifically inside cells infected with herpes simplex, HSV, or varicella zoster, VZV. A viral enzyme, thymidine kinase, activates it, adds a phosphate group. Then our own cellular enzymes add more phosphates, making the active triphosphate form.
So the virus itself helps activate the weapon against it, like a Trojan horse.
Exactly like that. And once it's activated, this triphosphate form inhibits the viral DNA polymerase, the copying enzyme. Even better, it gets incorporated into the growing viral DNA strand. But it's a faulty block. It terminates replication. The strand just stops growing.
Brilliant. Stops it right there.
And valacyclovir. It's basically acyclovir, but designed for better absorption.
Oh, okay.
It's a volume ester. Gets absorbed much better from the gut, then quickly converted to acyclovir in the liver and intestine. You end up with about 4 times higher plasma levels than with oral acyclovir.
So more bang for your buck, effectively. Less frequent dosing, maybe.
Often, yes. Better bioavailability is a big plus.
And famciclovir, also a prodrug.
Yep, converts to penciclovir. Penciclovir CA is another guanosine analog like acyclovir, maybe a bit less potent in the lab. But its key advantage is a much longer intracellular half-life. Once it's active inside the cell, it sticks around longer. That gives it similar overall clinical activity for HSV and VZV.
Got it. So clinically, where are these used?
FDA approvals cover initial and recurrent genital herpes, chickenpox, varicella, and shingles, zoster. Valacyclovir has extra approvals for cold sores, suppressing recurrent genital herpes, and importantly, reducing HSV transmission to partners by about 50%.
That's significant, and you need higher doses for VZV.
Yeah, VZV is just less susceptible. Valacyclovir is for severe cases needing hospitalization, oral forms for outpatient. Topical creams are less effective, but used for things like cold sores sometimes.
What about pharmacokinetic side effects? Kidney excretion is key.
Absolutely. All are excreted by the kidneys, so dose reduction is critical if kidney function is impaired to avoid accumulation and toxicity.
And the kidney crystallization risk with Vivia acyclovir.
Yeah, especially if dehydrated. Reversible kidney insufficiency can happen. Other common side effects are things like headache, nausea, rash, diarrhea.
Resistance, viral thymidine kinase mutations.
That's the main mechanism. Or less commonly, mutations in the viral DNA polymerase itself, and viruses lacking that thymidine kinase activity. They're also resistant to acyclovir and even ganciclovir, cross-resistance.
But is it common in healthy people?
Thankfully, no. Acyclovir-resistant HSV and VZV are rare in immunocompetent folks. It's more of a problem in immunocompromised patients. When resistance does happen, we turn to alternatives like foscarnet or cidofovir.
Okay, let's move to another important pair, ganciclovir and valganciclovir. Targeting CMV, right? Cytomegalovirus.
Primarily, yes. CMV can cause serious illness, especially in immunocompromised people. Ganciclovir is also a prodrug, a deoxyguanosine analog. In CMV-infected cells, a viral enzyme called UL97 protein kinase starts the activation process. Cellular enzymes finish the job, creating the active triphosphate.
And that active form hits the viral DNA polymerase.
Inhibits the polymerase and prevents the incorporation of the natural building blocks into the viral DNA, shuts down CMV replication.
And valganciclovir is the better absorbed oral version.
It's exactly. Valine ester, much better oral bioavailability. Gets plasma levels similar to IV ganciclovir. Huge convenience.
Where are they mainly used?
Critical for treatment and prevention of CMV disease in immunocompromised patients. Transplant recipients, for example. Things like CMV colitis, pneumonitis, retinitis, encephalitis. Approved specifically for CMV prevention in transplants and treating CMV retinitis.
Do they hit other herpes viruses too?
They do have activity against HSV, VZV, HHV6, others, but CMV is the main target. And like the acyclovir family, primarily kidney excretion, dose adjustment needed for impairment.
What are the major side effect concerns with ganciclovir?
The big ones are bone marrow suppression, neutropenia, low white cells, and thrombocytopenia, low platelets. Often show up after about a week. Needs careful monitoring.
Less common things.
Anemia, fever, rash, liver enzyme elevations, CNS effects like headache, confusion. It's a potent drug.
And resistance, different enzyme involved, UL97.
Right. Mutations in the CMV UL97 protein kinase, or the DNA polymerase. Importantly, if the mutation is just in the kinase, the virus is usually still sensitive to foscarnet and cidofovir.
But if both are mutated?
Then it's tougher. Often sensitive only to foscarnet. Resistance is more common in highly immunocompromised patients or those on long-term treatment.
Are there expanding roles for these drugs?
Yeah. Besides prevention in transplants, ganciclovir can reduce developmental delay and hearing loss in infants with congenital CMV. Also used for other severe herpesvirus infections sometimes.
Okay, let's switch gears to foscarnet. A direct inhibitor, you said, but with renal considerations.
Foscarnet is quite different. It's a pyrophosphate analog. It directly inhibits herpesvirus DNA polymerases by blocking a specific binding site. Crucially, it does not need activation by viral enzymes inside the cell.
Ah, so it bypasses those enzymes that often mutate to cause resistance to acyclovir or ganciclovir.
Exactly. That makes it valuable against resistant strains.
Approved for CMV retinitis and acyclovir-resistant HSV, also used for ganciclovir-resistant CMV and acyclovir-resistant VZV, always for.
Always for. Kidney excretion, dose adjustment needed. But the big issue is side effects.
The kidney toxicity, nephrotoxicity.
Yes, up to a third of patients can develop it. Elevated creatinine, sometimes more serious issues. More common with dehydration or rapid infusion, but often reversible. It can also cause significant electrolyte problems, low magnesium, low calcium, which can lead to arrhythmias or seizures.
Yikes. How do you manage that kidney risk?
IV saline hydration before and after each dose is key. And giving the drug slowly over an adequate period, that helps reduce nephrotoxicity.
Can resistance still develop?
Yes, through mutations in the viral DNA polymerase itself. Some CME strains can even become resistant to foscarnet, ganciclovir, and cidofovir.
Very tough.
So its niche is really for those difficult drug-resistant infections in immunocompromised patients.
That's typically where it fits in. Powerful, but challenging to use.
Next up, cidofovir. Broad spectrum and that interesting probenecid protection. Cidofovir is an analog of a different DNA building block. Deoxycytidine monophosphate gets activated inside cells to its diphosphate form. That active form competes with the natural building block for incorporation into herpesvirus DNA, disrupting replication.
And its spectrum is broad.
Very broad. Inhibits all human herpes viruses, plus pox viruses, papillomaviruses, polyomaviruses, adenoviruses.
Approved use is CMV retinitis in AIDS patients.
That's the FDA approval. But it's also key for infections caused by ganciclovir-resistant CMV, if the resistance is due to kinase mutations, and acyclovir-resistant HSV or VZV.
Excreted by kidneys again?
Yes, dose adjustment needed. And the nephrotoxicity management is absolutely critical.
The saline and the probenecid.
Always. Pre-treat with at least a liter of saline. Then probenecid is given 3 hours before, 2 hours after, and 8 hours after each dose to protect the kidneys by blocking uptake into renal cells.
Even with that, side effects can occur.
Oh yes. About a quarter of patients get neutropenia. Ocular issues, headache, GI upset, rash can also happen.
Resistance patterns. Can it work if foscarnet fails?
Sometimes. DNA polymerase mutations cause resistance. Some ganciclovir-resistant strains with polymerase mutations are also resistant to cidofovir. But interestingly, many foscarnet-resistant strains might still be sensitive to cidofovir. It's complex.
So clinically, it's another option for severe resistant CMV or HSV in immunocompromised patients. Also used preemptively in transplants and for some other nasty viruses like severe adenovirus.
That's right. Topical cidofovir has also been used for resistant HSV and warts.
Okay, a newer player, letermovir, specifically targeting CMV for prophylaxis.
Yes, letermovir has a very precise mechanism. It inhibits the CMV DNA terminase complex. This complex is required for the final step of cleaving and packaging the CMV DNA into new viral particles. Unique target.
And highly specific. No activity against other herpes viruses.
Correct. Very targeted. Its approved use is crucial. Preventing CMV infection and disease in adult CMV seropositive recipients of allogeneic hematopoietic stem cell transplants, a very high-risk group.
How's it handled by the body?
Metabolized by the liver, excreted mainly in feces. Kidney function usually doesn't require dose adjustment unless severely impaired. Drug interactions are important, though.
Like with cyclosporine.
Yeah, the letermovir dose needs to be decreased if taken with cyclosporine. And it can affect levels of other drugs, too, so interaction checks are vital.
What about side effects? You mentioned advantages.
Compared to other CMV drugs, its profile is quite favorable. Headache, nausea, diarrhea, peripheral edema are common. But crucially, letermovir does not cause kidney toxicity and is not myelosuppressive.
That's huge for transplant patients.
A major advantage.
And its efficacy. How well does it work for prevention?
A key study showed it reduced clinically significant CMV infection by 38% compared to placebo when given prophylactically to these high-risk transplant patients for about 14 weeks. While there are anecdotes about using it for treatment, resistance can develop, so its main established role is prevention.
Let's quickly cover the topical herpes treatments, trifluridine and vidarabine.
Right. Trifluridine is a thymidine analog incorporated into viral DNA, inhibiting synthesis. Active against acyclovir-resistant HSV, CMV, and vaccinia. Vidarabine is an adenosine analog, inhibits viral DNA polymerase. Both are only used topically. Specifically for herpes keratitis eye infections, and sometimes for acyclovir-resistant mucosal HSV infections, where local treatment is enough.
And just a quick look at the pipeline, investigational agents.
Shows the field is always moving.
Yeah.
Brincidofovir, a modified cidofovir, looked promising less kidney marrow toxicity, but oral trials had GI issues and failed for CMV prevention. 5E form still being looked at. Ribavirin inhibits a different CMV enzyme, UL97 kinase, and viral egress. Failed in prevention trials, but being tested for treating refractory CMV infections. Paritlivir inhibits the HSV helicase primus complex, a different target, being tested for acyclovir-resistant HSV. Amenamavir is another helicase primus inhibitor in development. Shows a constant search for new targets and better drug.
Wow, that's a deep dive into herpes viruses. Okay, let's pivot. Segment 3, battling respiratory viruses. Influenza, RSV, SARS-CoV-2, the ones that cause big outbreaks.
Absolutely. Let's start with influenza antivirals. The landscape here has really shifted over the years. The main class we rely on now are the neuraminidase inhibitors.
Oseltamivir, zanamivir, peramivir, Tamiflu is oseltamivir, right?
Correct. Their mechanism is clever.
Yeah.
They block the viral neuraminidase enzyme. This enzyme is like molecular scissors that the flu virus needs to cut itself free from infected cells so it can spread.
So these drugs stop the release, trap the virus.
Essentially, yes. Prevents efficient propagation. Oseltamivir, Tamiflu, is an oral prodrug, gets activated in the body. Approved for treating uncomplicated flu A or B if given within 48 hours, and also for prevention.
Less active against B than A, you mentioned.
That's right. Cleared by kidneys, dose adjust if needed, common side effects, nausea, abdominal pain, vomiting. There have been reports of CNS effects, especially in kids, but it's unclear if it's the drug or the flu itself. Resistance can happen, mutations in neuraminidase usually.
Zanamivir is inhaled.
Yeah, inhaled powder. Can be tricky for young kids or some elderly folks. Approved for treatment and prevention, big caution, can cause bronchospasm, especially in people with asthma or COPD. Not recommended for them.
But it's maybe better against flu B and some resistant strains.
It is more active against B than oseltamivir and active against some oseltamivir-resistant isolates. And resistance to zanamivir is less common, so it's a useful alternative.
Paramivir is the IV one, single dose.
Right, single IV dose, long half-life. Approved for treating uncomplicated flu, highly active against both A and B kidney excretion again. Main side effect is diarrhea. Resistance is rare in healthy people, but seen in immunocompromised.
So overall, these neuraminidase inhibitors work well for uncomplicated flu.
Yes, all three are effective, including against avian flu strains like H5N1. None are strictly FDA approved for complicated flu or hospitalized patients, but oseltamivir is considered the go-to in those serious situations.
Timing is key, though, within 2 days of symptoms.
That's when they work best. Reduce symptoms by about a day. But even later, for hospitalized patients with pneumonia, treatment is still recommended, might reduce complications and death risk.
And for prevention, oseltamivir and zanamivir?
Yes, approved for prophylaxis, important in outbreaks in institutions, or for high-risk people exposed who aren't vaccinated.
Yeah.
Efficacy is pretty good, 70–90%.
And the vaccine interaction, don't take them right around getting the live vaccine.
Correct. Since they reduce virus release, wait 2 days before or 2 weeks after getting the live attenuated flu vaccine so they don't interfere with the immune response.
Okay, now the novel mechanism, baloxavir, targeting a different enzyme.
Yeah, this was exciting. Baloxavir inhibits the influenza virus's polymerase acidic protein endonuclease, the PA endonuclease.
The cap-snatching enzyme.
Exactly. It's crucial for the virus to start making its mRNA. Blocking this stops viral protein production very early.
Approved as a single oral dose for treatment and post-exposure prevention.
Yes, for uncomplicated flu in people 12 and up, within 48 hours of symptoms. Broad spectrum hits A and B, including avian strains and even strains resistant to the neuraminidase inhibitors.
Efficacy similar to the NNIs.
About the same. Reduces symptoms by about a day. Effectiveness in hospitalized patients isn't known yet.
Resistance can still happen, though, even after one dose.
It has been reported. Mutations in the PA protein. Shows how adaptable flu is. Side effect-wise, maybe less nausea vomiting than oseltamivir.
And watch out for taking it with dairy or mineral supplements.
Right, those can lower drug levels, and same caution applies regarding the live flu vaccine.
We should briefly touch on the adamantines, amantadine, rimantadine, old drugs.
Very old mechanism, inhibiting the M2 protein, affecting uncoating. Worked against influenza A once.
But resistance is widespread now.
Absolutely rampant, so they are not recommended anymore unless you somehow know the strain is sensitive, which is basically never.
Got it. Let's move to RSV, respiratory syncytial virus. Ribavirin is the main one here, but controversial.
Yeah, ribavirin is interesting. A guanosine analog inhibits lots of RNA and DNA viruses in the lab. Multiple mechanisms. His RNA synthesis, capping, can cause lethal mutations.
Broad activity in vitro, but FDA approved only for RSV and hepatitis C combo therapy.
Correct. For RSV, it's specifically the aerosolized form, approved for hospitalized infants and young children with severe lower respiratory tract infections. Needs prolonged administration via a special generator. Most effective early.
But the aerosol has serious side effects.
It can. Bronchospasm, sudden worsening of breathing, especially in infants, can precipitate in ventilators too. Plus, it's mutagenic and teratogenic in animals.
So not for pregnant women, and healthcare workers need protection.
Definitely. And the efficacy debate. Early studies showed modest effects, but later analyses cast doubt. The American Academy of Pediatrics does not recommend routine use anymore.
But maybe a rule in transplant patients.
Some retrospective studies suggest it might reduce progression and mortality in stem cell transplant recipients with RSV. Oral ribavirin seems similar to aerosolized in one study for them. It's also incredibly expensive.
Right. What about palivizumab for RSV?
That's different. It's a monoclonal antibody targeting the RSVF protein, approved purely for prevention of severe RSV disease in high-risk infants, a crucial prophylactic tool.
Okay, now the big one recently, SARS-CoV-2 antivirals. Rapid development there.
Yeah.
Remdesivir leads the pack.
It was one of the first out of the gate. Converts in cells to an adenosine triphosphate analog, inhibits the RNA-dependent RNA polymerase of SARS-CoV-2 and other viruses, stops replication.
Approved for hospitalized patients 12 and up.
Yes, requiring hospitalization. Shown to shorten hospital stays in those with lower respiratory tract disease. NIH recommends it for hospitalized patients needing supplemental oxygen, given intravenously.
Any contraindications or issues?
Not recommended if kidney function is very low, GFR 30. Liver enzyme elevations can occur, so monitoring is needed. And crucially, don't give it with chloroquine or hydroxychloroquine as they inhibit its activity.
The pandemic really pushed investigational drugs forward quickly, didn't it?
Unprecedented speed. We saw favipiravir, approved in Japan for emerging flu. Molnupiravir, an oral drug, showed about 50% reduction in hospitalization death risk for mild-moderate COVID in trials. Oral protease inhibitors entered trials.
Just shows what focused research can do in a crisis.
Absolutely. It was a remarkable scientific response.
Okay, let's briefly cover segment 4, niche antivirals. HPV, poxviruses, picornaviruses.
Right. For HPV, human papillomavirus, and poxviruses, interferon alpha has a role. It inhibits many viruses. FDA approved for intralesional treatment of external HPV warts.
Injecting it right into the warts. Effective.
Resolves lesions in about half the cases, but recurrence happens in about a quarter.
What about imiquimod? That's different, right? Immune modulator.
Exactly. It's a cream, a toll-like receptor 7 agonist. It basically tells your body to make its own interferon alpha and other cytokines. Approved for external HPV warts. Resolves lesions in about 40%.
And for pox viruses like smallpox or monkeypox?
Tecovirimat. FDA approved for smallpox, also inhibits monkeypox and vaccinia. But we've already seen resistance emerge in one case, unfortunately. Viruses adapt.
And for picornaviruses like polio, investigational drugs?
Pocabavir is one example. Inhibits virus uncoating, being developed to reduce poliovirus shedding.
It's a challenge.
Resistance develops rapidly, a common issue with drugs targeting these highly mutable viruses.
Okay, that brings us to segment 5, hepatitis B virus, HBV. A very different fight, you said. More about suppression, the long game.
Precisely. Chronic HBV isn't usually cured with current drugs. We have 8 approved drugs in the U.S. in 2 main classes.
Nucleoside analogs and interferons.
Right. Nucleoside analogs inhibit the viral reverse transcriptase, blocking replication. Interferons mimic and boost the body's natural defenses.
And the goal isn't cure, but reducing liver inflammation.
Exactly. That inflammation leads to fibrosis, cirrhosis, and liver cancer risk. We aim to prevent that progression.
What outcomes can we achieve?
We often get virologic suppression knocking down HBV replication, biochemical responses, improving liver function tests, even histologic responses, improvement in liver scarring seen on biopsy. But the big limitation, loss of the surface antigen, HBsAg, and developing protective antibodies, HBsAb, true immunological clearance, is uncommon. Often means lifelong therapy.
Let's focus on the nucleoside analogs, their first line.
Generally preferred, yes. Favorable side effect profile, easy administration, usually 1 pill once a day.
What about the warning for liver issues, lactic acidosis?
That warning exists, but it's based on older HIV drugs. It has not been observed in the clinical trials specifically for these drugs used for chronic HBV. The risk is much, much lower for HBV patients.
What is the main risk then?
It's actually stopping treatment. Virus rebound and a subsequent hepatitis flare can happen in up to 20% of patients. Rarely, it can lead to liver failure, so stopping is done very carefully.
And the newer drugs are better for resistance. Entecavir, tenofovir.
Much lower rates of resistance compared to older ones like lamivudine or adefovir.
Yeah.
Huge factor for long-term success. If replication is suppressed, liver improvement happens in 60–75% of patients.
Let's run through some specific ones quickly. Lamivudine, old, high resistance.
Yes, resistance approaches 70% after 5 years. Limits its long-term use. Emtricitabine is similar, often used in combo pills with tenofovir.
Adefovir. Better than lamivudine, but still significant resistance over time.
Resistance develops slower, but still hits 20–30% after 5 years. Kelvivudine also had resistance issues limiting its use.
Entecavir, more potent.
Very effective. Blocks HBV polymerase multiple ways. Active against some lamivudine-resistant strains, but needs a higher dose. Resistance is uncommon if treatment naive, but can happen with prior lamivudine resistance. Entecavir-resistant strains usually respond to tenofovir.
And tenofovir, the star player for resistance, TDF and TIF forms.
Yes, potently inhibits HBV. And the really key point, clinically significant resistance to tenofovir has not been observed with up to 7 years of therapy.
That's incredible. Makes it a cornerstone. TDF had some kidney bone concerns.
Warnings exist due to similarities with other drugs, but large HBV trials didn't find significant risk. Small declines in kidney function and bone density were noted, so monitoring is advised.
And TAF is the newer form, less systemic exposure.
Right. Greater stability, higher levels in liver cells, less in the bloodstream. Results in much less impact on kidney function and bone density compared to TDF. Both are approved for HIV and HBV.
Okay, what about interferons for HBV? Declining role.
It's definitely declining. They have broad antiviral activity, boost immune response. Pegylated forms allow once-weekly dosing.
But side effects are common and rough.
Very common. Flu-like symptoms, fatigue, depression, confusion, blood count issues. Pegylated IFN alpha-2A is approved for HBV. Historically cleared viral markers in about a third of cases, cleared surface antigen in maybe 8%.
So might still get it.
Response is better with lower viral load, higher liver enzymes initially, less effective in immunocompromised folks. Combination with nucleos, TIDES can boost rates, but tolerance is poor. Its niche now is usually specific HBV genotypes or patients wanting a finite treatment course, like women planning pregnancy. Also used for hepatitis D.
And crucially, not used for hep C anymore.
Absolutely not. Which brings us perfectly to our final segment.
Segment 6. Hepatitis C virus, the cure revolution. This is a massive story.
Nothing short of a paradigm shift in medicine. Combination directly acting antiviral therapy DAAs is the standard of care for everyone with chronic HEV, regardless of genotype or liver damage.
These DAAs target specific HCV proteins.
3 main targets: the NS5B RNA polymerase, the NS34A protease, and the NS5A protein involved in replication.
And treatment is short, 8 to 24 weeks.
Unbelievably short compared to the old interferon days. The goal is sustained virologic response, or SVR.
Undetectable virus 12 weeks after treatment ends.
And SVR is considered synonymous with cure.
Cure, that's the word. Durable suppression, lower mortality, reduced cancer risk. Even in patients with cirrhosis, it's genuinely revolutionary.
Cure rates are over 90% with first-line regimens. Even if the first attempt fails, specific retreatment regimens exist. Sometimes adding ribavirin or extending duration helps overcome resistance issues. Checking for drug interactions before starting any DAA is absolutely essential.
Are they generally well tolerated?
Remarkably well tolerated for most people. The main black box warning is about potential HBV reactivation in co-infected patients if the HBV isn't treated. But it's manageable, and HCV treatment should not be delayed because of it.
Let's talk sofosbuvir, the game changer.
It really was foundational. A prodrug inhibits the HCV NS5B polymerase, terminates RNA replication. Broadly active.
And resistance is rare.
Clinically, yes. Very rare to see resistance emerge during treatment. Available alone or in fixed-dose combos. Kidney clearance, but studies show it's safe even in end-stage renal disease dialysis patients.
The one big interaction is with amiodarone, bradycardia risk.
Yes, severe bradycardia risk, especially if also on a beta blocker. Extreme caution needed there.
What about sofosbuvir combos? So flightopasphere.
Ledapasphere is an NS5A inhibitor. Combo effective for genotypes 1, 4, 6. Usually 12 weeks, sometimes shorter or longer depending on the patient's specifics.
Ledapasphere cleared by the liver. Absorption affected by food and antacids.
Yes, liver clearance, okay with mild, moderate kidney issues. Take with food. Avoid antacids PPIs around dosing time. Very well tolerated.
Sofosbuvir velpatasvir. Velpatasvir is another NS5A inhibitor, broader.
Similar to ledapasphere, but better against genotypes 2 and 3. Pangenotypic combo used for treatment-naive patients, all genotypes, all fibrosis stages, even decompensated cirrhosis. Therapy duration usually isn't shortened, minimal side effects.
Then the triple combo, Zobel-voxiloprevir, as a protease inhibitor.
Voxiloprevir is the NS3-NS4A protease inhibitor. This combo is active against genotypes 1 to 6, recommended mainly for retreatment after failing a prior DA regimen or for naive genotype 3 with cirrhosis.
Need to add ribavirin sometimes for tougher cases.
Yes, especially for NS5A experienced genotype 3, usually 12 weeks. But because of the protease inhibitor, not for decompensated cirrhosis or severe kidney impairment, watch for interactions via liver metabolism. Headache, fatigue, diarrhea, nausea are common side effects.
Sofosbuvir. Docetaxel is available alone.
Yes, the only NS5A inhibitor available individually. Binds NS5A, inhibits replication and assembly. Approved with sofosbuvir for genotypes 1 and 3, 12 weeks. Safe in decompensated cirrhosis. Liver metabolism, dose adjustments needed with interacting drugs. Uncommon side effects.
Now, protease inhibitors as a class, they block that NS34A protease.
Right. Mimic the viral protein, block the enzyme's cutting action. Crucial point for the whole class. Metabolized by the liver, so should not be used in patients with decompensated childhood PUB or C cirrhosis. Monitor liver tests monthly.
Simipravir, older PI, not really used now.
Had resistance issues with the common polymorphism, Q80K. Newer options are better. No longer recommended.
The four-drug combo, paritaprevir, virimbin, isviridosabuvir, complex.
Very. Paritaprevir, PI, boosted by ritonavir, HIV drug used just as booster here. Ametust, NS5A. Dasabuvir, NS5B non-nuke. Approved for genotype 1B. Add ribavirin for 1A. Significant drug interactions due to ritonavir. Contraindicated in decompensated cirrhosis. Monthly liver monitoring.
Elbasvir, grasapravir, NS5A plus a PI.
Yes. Active against genotypes 1 and 4. Need baseline resistance testing for genotype 1A if certain polymorphisms exist. Add ribavirin and extend therapy. 12-16-week duration depending. Okay, with kidney disease dialysis, but again, contraindicated in decompensated cirrhosis. Generally well tolerated.
And the newest combo, glycoprevir, pabrentasvir, pangenotypic PI and NS5A.
Right, both components have high barrier to resistance, active against genotypes 1 to 6. Baseline resistance usually doesn't impact efficacy, except maybe some genotype 3 cases.
Duration is often just 8 weeks for treatment naive, even with cirrhosis.
Yes, remarkably short. Longer courses, 12-16 weeks. For treatment experienced or prior NS5A failure, take with food. Cleared via bile, so okay in severe kidney disease. But being a PI-containing regimen, not for decompensated cirrhosis. Weak CYP inducers, but they inhibit P-glycoprotein and other transporters, so potential for interactions increasing levels of other drugs. Generally well-tolerated, mild side effects.
Finally, let's revisit ribavirin, the adjuvant.
The versatile adjuvant,
Yeah.
synthetic guanosine analog.
Yeah.
Weakly inhibits replication, but main HCV mechanism isn't fully clear. Might promote lethal mutations, might stimulate immune response.
Huge historical role with interferon, now used to augment DAAs sometimes.
Exactly. But it has significant side effects, especially hemolytic anemia, also rash, fatigue.
Yeah.
And it's teratogenic, cannot be used in women of childbearing potential. Strict precautions needed.
So why still use it if DAAs are so good?
Because there are still specific situations where it helps. It can boost SVR rates by 5%, especially in tougher cases like genotype 1A or certain resistance profiles. Often added in retreatment regimens for cirrhotic patients to maintain high cure rates with shorter durations. Crucial for improving outcomes in treatment-experienced genotype 3, which is still tricky. Also used in decompensated cirrhosis, where PIs can't be used, or resource-limited settings.
Doesn't seem to select for resistance itself.
No known resistance mutations associated with it due to its broad effects. Kidney excretion, needs dose adjustment, and anemia monitoring if kidney function is poor. Also effective for chronic hepatitis E in immunosuppressed patients.
And just to hammer it home, interferon plus ribavirin for hep C.
Obsolete. History. DAAs are far superior in efficacy and tolerability. What a revolution.
So, wrapping this all up, what does this deep dive mean for you, our listener? We've covered a huge amount of ground.
We really have. From the basic nature of viruses dictating our strategies to the incredibly specific ways drugs target herpes viruses, the dynamic fight against respiratory viruses like flu and SARS-CoV-2.
And that truly amazing journey from just managing chronic hepatitis B to actually curing chronic hepatitis C. It's hard to overstate that shift.
Think about what stood out. Was it the sheer ingenuity of drugs like acyclovir, using the virus's own enzymes against it? Or the constant battle against resistance requiring combination therapies?
Or maybe just the profound impact, moving from managing chronic, debilitating diseases to offering cures that give people their lives back.
Absolutely. So here's something to ponder. What's fascinating here is, given how viruses constantly evolve, how resistance emerges, how new pathogens appear, what's next for antiviral strategies?
Will we lean more into boosting the host immune response? Or find totally new ways to block viruses that we haven't even thought of yet?
What unexpected threats or maybe even therapeutic opportunities using viruses might be just over the horizon? It's a field that never stands still.
Definitely something profound to think about.